Done. Good morning, respected teachers, my teachers and my dear colleagues. I am talking about IgG4 related kidney disease, a newly recognized entity. So, introduction. IgG4 related disease is a newly recognized multi-system disorder. It's characterized by high plasma levels of IgG4 and dense infiltration of IgG4 positive cells in the several organs. First, it was recognized in the pancreas in the syndrome of autoimmune pancreatitis. Later, it was found to be involved along with the pancreas in the disease process. We present here clinical-pathological features of 3 patients. The diagnosis having IgG4 related tubular interstitial nephritis in the last 3 years in our institution. Patient 1 is a 44-year-old gentleman who is not a hypertensive or a diabetic. Presented to our hospital in July 2009 for the medicine services with fever and cough and found to have pneumonia and X-ray blood effusion. Treated with multiple course of antibiotics, but care at that time care was 2.2 mg per deciliter. Was referred to nephrology services, thought secondary to infection, and we decided to follow him up. Later on, he received ATT at a local hospital at his place for 6 months, but continued to have persistent symptoms. So after 1 year, he again presented to our department. At this time, his creatinine was 2.4 milligrams, urine showed no segments or proteinuria. Total serum globulin was 7 grams per deciliter and ESR was 56. So at this time, he was detailedly evaluated. CT thorax showed bilateral pulmonary nodules and mediastinal nodes. CT abdomen showed enlarged kidneys with hyperdense areas in the right kidney and liver, epiosplenomegaly and retrograde nodes. Mediastinal and abdominal lymph node biopsy was reported as a reactive hyperplasia. Liver biopsy then showed dense lymphoplasmacytic infiltrate with fibrosis. Kidney biopsy was done this time, was creatinine was 2.4 and in view of imaging features showed very suspected fact lymphoma, dense lymphoplasmacytic infiltrate with interstitial fibrosis, and there is no evidence of lymphoma or granuloma on the biopsy. His age levels are normal, angiotensin levels are normal, and S1 was negative for MLAN. Again, he lost for follow-up and was apparently asymptomatic. So he came back to our hospital again on August of 2012 with signs of exactly after 2 years of signs of volume overload and found to have a serum creatinine of 7.7 milligrams and required hemodialysis for a couple of sessions. He went underwent repeat USG and MRI. I have pictures of this is a ultrasound picture shows hyperechoic lesions in the kidney, more of pneumophactic lesions, and this is an enlarged kidney, grossly enlarged kidney. And this is a CT abdomen. We couldn't contrast enough because of renal dysfunction. The CT abdomen then showed hypodense lesions, more of cortical-based wedge-shaped lesions in the right kidney and a grossly enlarged left kidney. In the light of these features, a repeat renal biopsy was done to see what's happening. It showed similar features as the previous biopsy. It showed densely sclerotic interstitial, infiltrated fibroblast in a storiform pattern, and dense lymphoplasmacytic infiltrate. Immunofluorescence revealed beyond the antibody of any deposits. Immunohistochemistry was strongly positive for IgG4 positive plasma cells. This is the HND stain of the biopsy. Shows eosinophils and dense infiltration of plasma cells. And this is the class stain shows storiform fibrosis, the form of whirly appearance. And immunohistochemistry done for IgG4 positive plasma cells showed dense infiltration of IgG4 positive plasma cells, and the ratio was well beyond 40% of the recommended criteria. Again, IgG4 levels was done. So it was very high, 2,609 milligrams. In fact, it's the lowest. Normally, it is the lowest immunoglobulin which is seen in the body. It was confirmed to have IgG4 related renal disease based on clinical features, serology, histopathology, and imaging studies. He was started on steroids, following about 3 to 4 weeks later, he This is the course of his treatment. Initial first biopsy was reported as inflammatory pseudotumor, but he didn't turn up for further management. And a gradual progression. Second biopsy done steroids as a dramatic response, though not as dramatic because of long course of illness prior to starting treatment. We have two more patients. The second patient is similar, 56-year-old gentleman, hypertensive in 16 years. Incidentally, found to have a creatinine of 2.5 milligrams with normal size kidneys and bland urinary sediments on a routine checkup. Complement levels were normal, there was no MBAL. Started in 2010, showed the biopsy of the prostate showed eosinophilic prostatitis. At this time, serum creatinine was 1.3 milligrams per deciliter. USG abdomen in this time, when interacted was with the renal dysfunction, showed bulky kidneys for right kidney being 11.9 centimeters and left being 11.8 centimeters, with normal CMT, no focal lesions. So, renal biopsy done again because of no proteinuria and unexplained kidney dysfunction in this patient showed similar features as the previous patient. IgG4 level was very high, 1040 milligrams per deciliter. Again, he was started on steroids at the dose of 0.6 milligrams, following which his serum creatinine has come down to 1.8 milligrams. Unfortunately, he has developed a steroid-related complaint, that is steroid-induced diabetes. So, he has changed to mycophenolate as of now. This is the third patient, just diagnosed probably a month later. A 62-year-old male was diabetic for 15 years. Presented with generalized weakness and weight loss for 2 months duration. The serum creatinine was 2.1. This was the outset report. We don't have the baseline in this patient. Urine examination showed no active sediments or proteinuria. Physical examination was negative for lymphadenopathy or organomegaly. Hemoglobin was 9.9, ESR 115. Serum creatinine in our hospital for 1 month of 2.1 was 3.8 milligrams. Globulins were elevated and serum erythropoiesis was negative for 10. Ultrasound again showed bilateral bulky kidneys. Kidney biopsy was done that showed similar features as the previous two biopsies. The serum IgG4 was moderately elevated, but beyond the upper limit of the normal range, that is recommended range. That is 206 milligrams per deciliter. Again, he lost follow, but we couldn't initiate him on steroids. So, in summary, among all the patients, all 3 patients had minor moderate renal failure at the beginning of their illness. All 3 patients are males in our city. All of them had bulky kidneys, and 1 patient had involvement or multi-system involvement with lungs, kidney, liver, and generalized lymphadenopathy. All patients had similar histology and high IgG4 levels. 2 patients were started on steroids and 1 lost to follow. 1 patient was dialysis dependent, was able to stop dialysis. The other patient's creatinine reduced to 1.8 milligrams from 2.5. So, the review of the literature process is a recently recognized process. The first description of IgG4 related tubulointerstitial nephritis was made in 2004. Earlier, it was known with various organs involved with various names. The estimated incidence, most of the literature is from Japan. Estimated incidence in Japan is about 0.28 to 1.08 per 1 lakh population of all the IgG4 related diseases. This is about IgG4 related diseases. Mean age of disease onset is 58 years, and most organ involvement is pancreas. Most common organ involvement is pancreas, salivary glands, retroperitoneal fibrosis, kidney, lung, and lymph node. The pathogenesis is exactly not known. The various factors have been implicated: genetic, autoimmunity, and infections. Predominantly, there is activation of type 2 helper cells with increased production of interleukin 4,
The next paper is acute kidney injury pregnancy, a single center experience from South India. The gender is Kumar from Chennai.
College, and I am going to present acute kidney injury in pregnancy as single center experience from Department of Nephrology, Madras Medical College. Aim is to study the incidence, clinical spectrum, maternal and fetal outcome of pregnancy related acute kidney injury. It's a prospective study done between August 2010 and July 2012. All the patients who were admitted to the nephrology department with pregnancy-related acute kidney injury were included. Detailed clinical history and examination were done. Laboratory tests included urine analysis, blood biochemistry, sepsis screen, and DAC workup in appropriate cases. Duration of dialysis, renal outcome, maternal and fetal outcome were also noted. Renal biopsy was done for clean indications and also when renal failure was unexplained for more than 3 weeks. Patients who had a serum creatinine of more than 1.5 mg per deciliter or eGFR of less than 60 ml per minute at 3 months of follow-up were considered to have progressive CKD, and we excluded about 13 patients who did not have 3 months of follow-up. Statistical analysis, patients' demographics were done with mean, median and range, and univariate analysis of the data was done. Results. The total number of patients with acute kidney injury during the study period was 1,268, out of which 94 had pregnancy-related acute kidney injury, contributing to about 7.4% of total AKI. The age of the patient ranged from 17 to 42 years, with the mean being 25.3 years, and most of the patients were in the 21 to 25 years age group. The most common cause of pregnancy-related acute kidney injury in our study was sepsis, contributing to about 39%, PAH contributed to about 20%, obstruction, acute diarrheal disease, traumatic microangiopathy contributed to about 8 to 10% each, and the other common causes were lupus and postpartum hemorrhage. The mean time of diagnosing PAH was 7 months of pregnancy, and the mean BP in this cohort was 150 over 100 millimeters of mercury. Evidence of H syndrome was found in 4 patients. 3 patients progressed to CKD and 2 patients expired. Live baby was seen in 10, and adverse fetal outcome occurred in 8. 37 patients had sepsis, with the most common organism being E. coli. The mean total WBC count was 14,000. Out of 37 patients, 3 had septic abortion, and the rest 34 had postpartum sepsis. 32 patients were dialysis dependent, 18 recovered, 13 progressed to CKD, and 6 expired. Evidence of disseminated endoscopic violation was found in 9 patients. E. coli was the commonest organism isolated from the sepsis group, and it was followed by Klebsiella. We also had about 4 patients with Staph aureus sepsis and 5 patients with Acinetobacter in the vigilance lab. About 7 patients had traumatic microangiopathy, and all the 7 patients were biopsy proven. And all 7 patients were dialysis dependent, and we gave plasma for 2 patients, up to 1 recovered. The rest 6 progressed to CKD. We had 2 patients who presented with rapidly progressive glomerulonephritis during pregnancy, but unfortunately both patients had IUD and spontaneous suspension of the fetus at 6 and 7 months of pregnancy respectively. And upon renal biopsy following the delivery, we found class 4 lupus with presence in 1 and quasi-immune necrotising glomerulonephritis with presence in the other patient. And this patient proved to be anti-MPO positive later. About 79% of the pregnant mothers were dialysis dependent at presentation, and the mean duration of dialysis dependence being 14 days. Maternal outcome, about 56% of mothers recovered completely, 35% had partial recovery, and they have progressed to CKD at 3 months of follow-up, and the mortality rate observed was 9%. So this table depicts the individual groups analysis, which highlights that sepsis was the predominant group contributing to CKD as well as mortality, and the other mortality occurred in PAH group, and the other cohorts there was no mortality observed. Regarding the fetal outcome, alive and healthy baby occurred in 43%, and 55% had adverse fetal outcome in the form of spontaneous abortion or IUD or stillborn. And again, sepsis was the most common contributing factor for adverse fetal outcome. And we did renal biopsy in 32 patients, 49 necrosis contributed to 11, traumatic microangiopathy occurred in 7, acute tubular necrosis in 6, lupus nephritis in 4, and other glomerular diseases occurred in 4 patients, which included diffuse mesangial proliferation, chronic aging nephropathy, FSGS, and anti-vascular vasculitis. So this was the biopsy from the patient who had anti-vasculitis, and the arrows point towards the fibrillar necrosis. This is also from the same patient, a high magnification showing a fibroinfant proliferation in a blood vessel. This is from a patient who had traumatic microangiopathy, and this is a trichrome screen, and the arrows pointed towards the fibrillar This is a biopsy sample from another patient who had cortical necrosis, and the typical post-coronary is very well appreciated. When we analyzed the risk factors of progression to CKD, we found that mean platelet count, peak serum creatinine, and iris hypertension presentation, and cortical necrosis and TMA in biopsy, they were statistically significant in contributing towards progression to CKD. This table shows a comparison of our present study with other studies, other Indian studies. The second column shows our same departmental study done about 5 years back and published by Professor M. Jayakumar. The third column shows the study from Professor Jayaprakash from Banaras University, and the last column shows the study from Professor Shivakumar from SIMS. So what we found that we found similar instance of pregnancy related kidney injury, but what we found is that there is an increasing trend in the thrombotic microangiopathy and glomerular diseases group, and we also found a decline in the postpartum hemorrhage group. And the mortality observed in our study was 9% compared to around 20% in the rest of the studies. So conclusion of this study, the incidence of pregnancy related injury was 7.4%, with sepsis and preeclampsia being the most common causes. 78% were dialysis dependent, 56% recovered completely, 38% had only partial recovery and progressed to CKD. Mortality rate observed was 9%, and 58% had adverse field outcome.
Now the paper is open for comments and questions if there is any.
What happened to the baby? The baby died or baby was alive?
Sir, it was IUD.
IUD?
Yes.
And what were the biopsy findings in the baby?
Sorry, sir, we don't need
Why I am asking is, this is the only case report available in the world published in NEJM stating that ANCA is not an epiphenomenon, ANCA is pathogenic. Because there is a controversy whether anti-neutrophilic cytoplasmic antibodies are really pathogenic or not. This is the only case report published in NEJM proved that the ANCA antibodies migrated from the maternal circulation into the fetus and produced ANCA in the baby. So it's a great opportunity that has been lost.
When we reviewed the literature, sir, all these 5 patients, they had a fetal demise, and about 5 cases of maternal president pregnancy has been reported. This is the 6th case.
No, first case when it came to like that, so you missed a great opportunity. That's what I am saying.
Thank you, sir. Yes, thank you.
Acute kidney injury is one of the significant risk factors for the development of the chronic kidney disease. So prevention of this acute kidney injury or managing it in early stages may prevent the chronic kidney disease or the progression of the chronic kidney disease. Now I request my co-chairperson to introduce the speaker, Professor Jayakumar.
I invite you introducing Dr. K.P. Jayakumar, Professor and Head of the Department of Nephrology, Kota Medical College. We have been associated with Jayakumar for quite some time. We have his MD in medicine, the place where I am working, Madras Medical College. Currently, he is heading the division of nephrology, Kota Medical College. The efficient way. Recently, I have started doing the cadaver transplant as well. Without wasting much time, I invite Professor Jayakumar to deliver his lecture.
Respected members of our society, at the outset, let me pay my sincere thanks to Dr. Suresh, Dr. Ramana, and the team for having this wonderful talk. Now, today the topic for discussion is AK to CKD. In 1952, in the Lancet, Lau et al. Have listed series of acute renal failure patients
going on in the interstitium or in the form of hydrotic changes. So that rather it's a surface. At one side there is a tubular epithelial injury. How there is interstitial fibrosis taking place in this group of patients? Hence, in this discussion, we should approach this AKD to CKD axis in these ways. What is the traditional concept of AKD recovery? AKD as a risk factor for chronic kidney disease, its progression and end-stage renal disease. Would there is an opposite link? Could be CKD is an independent risk factor for AKD. Then what is the parallel biological research going on in AKD to CKD axis? And last, a little bit of our experience on leptospirosis AKD going for CKD. This is a traditional concept. As in case of any tubular injury, there will be initially hyperperfusion, followed by initiation of this AKD. Then it's contributed by extension, maintenance, and repair. Previously, we thought almost 100% if there is no acute mortality in the acute phase of acute kidney injury, everybody will have a smooth recovery. But these are the studies showing. First one, what is the impact of acute kidney injury on the genes of end-stage renal disease? There are various important papers. The first one from Lovector came in Kidney International. They have identified two groups of patients. One group underwent dialysis requiring AKD, another group that there was no dialysis support. Followed up of those patients who had dialysis-free interval after 30 days were enrolled in this study. Surprisingly, after 6 years of follow-up, 12% of these dialysis-requiring AKD group went into end-stage renal disease. On the other side, the incidence was somewhere around 0.03%, showing definitely AKD may be having a definite impact on the genes of end-stage renal disease in the future. Another study also, the expanded data showed the same group, the same pattern of study. One group who had AKD with the dialysis support and another group without support. Surprisingly, 3.3% times that of ESRT occurrence compared to other populations where there was no dialysis support. Another